Hello, everyone, and welcome to today's webinar, and thank you for joining us. I'm Annie Robitaille, and I hold the Commissioner Ottawa Research Chair with the Center of Excellence in Frailty-Informed Care at Pearly Health, and I'm also an Associate Professor at the University of Ottawa. Today's presentation is entitled Understanding Healthcare Trajectories of People Living with Dementia. Following today's presentation, there will be some time for questions. You can ask your questions by writing them in the Q&A box at the bottom of your screen. We will do our best to go through all of your questions. We also ask that you take a minute at the end of the webinar to complete a short survey that will appear on your screen when you exit. Today's webinar will be recorded and will be made available shortly after the webinar on the Pearly Health Center of Excellence website. It is my absolute pleasure to introduce Raquel Betini and Liudmila Husak. Raquel Betini has a PhD in public health from the University of Waterloo and is a project lead at the Canadian Institute for Health Information. During the last 7 years, she's worked on several projects, such as the impact of COVID-19 in long-term care and trajectories of people living with dementia in the healthcare system. Liudmila Husak is a manager of health science analytics at the Canadian Institute for Health Information. Liudmila joined CoE in 2006 and is responsible for the development and release of a variety of analytical products. She holds a Master's of Public Health in Epidemiology from the Emory University in the United States. Please join me in welcoming Raquel Betini and Liudmila Husak to share their important work.
Thank you so much, Annie. So Raquel and I are excited to present to all of you today. Thank you so much for joining us. So I'll start with a few slides to kind of get us set up and then pass it on to Raquel to guide us through the findings. So today we're presenting the findings of our report, a step towards understanding the trajectories of care for people living with dementia. We'll start with our land acknowledgement. Raquel and I work in Toronto office of CoE, and we respectfully acknowledge that our office is located on the traditional territories of the Wendat, the Anishinaabe Nation, the Haudenosaunee Confederacy, and the treaty lands and territory of the Mississaugas of the Credit. We recognize that this land is now the home of many diverse First Nations, Inuit, and Métis people. Go to the next one. So first of all, for those of us unfamiliar with us, CoE is a pan-Canadian not-for-profit organization that hosts extensive linkable pan-Canadian data across the healthcare continuum. We have about 28 data holdings with 10 billion of records, 3 terabytes of unique records, and as I mentioned, pan-Canadian coverage. So we listed a few databases, or actually all of them, that CoE hosts. By type of care, patient-reported data, health spending, and health workforce. And you can see that by types of care, we noted the first 6 that we used for this dementia report as they identify people living with dementia. So this database includes hospital and emergency databases, mental health, home care, long-term care, rehabilitation, and pharmaceuticals-related data sets. We also include on the health spending side data from our physician billing data. And Raquel will cover it all in more details as we go through the presentation. So we were very excited to work on this project because it was a truly collaborative initiative. We received financial support from the Public Health Agency of Canada to contribute to the Enhanced Dementia Surveillance Initiative and worked with PHAC as well as provincial partners on the report that was released on April 11th, 2024. Our provincial partners included Ontario, Quebec, and British Columbia. We used 8 data holdings to explore topics of care transitions, disease progression, socio-demographic factors, caregiver experiences, and more. We were also happy to include the perspectives of 4 caregivers and healthcare providers that added a lot of context to the findings. You can find the report on the website, but for now, I'll pass it on to Raquel to guide us through the findings.
Thank you, Liudmila. So I'm going to start talking a little bit about methodology. So we started by identifying people living with dementia by looking at their very first record of dementia during a hospital stay or a visit to a primary care provider, or by looking at any anti-dementia prescription drug that they received in the year 2017. And we follow that cohort of people that identify as have their first record of dementia in 2017. We follow them until 2022, recording their healthcare interactions. And for our data set, we looked only data from Newfoundland and Labrador, Ontario, Alberta, and British Columbia, because those were the provinces that had nearly complete information for all the data sets that we needed to run this analysis and look at the interactions with the healthcare sectors, and also looking at all these years. So here, just explaining again how we did that. And again, like we start by identifying people that had a first record of dementia in 2017 by looking at hospitalizations, visits to primary care provider, or who had an anti-dementia prescription drug. And then we follow that cohort through the years until 2022, and we look at their interactions specifically to home care and long-term care, and that looking at the different interactions, if they went to home care or if they went straight to long-term care. And we also looked at hospitalizations that happen before an admission to home care, or hospitalizations that happen before a transition to a long-term care. So today we're going to present some of our key findings. So we looked at the trajectories of people living with dementia in the healthcare sectors, and we found that more than half of people living with dementia had home care as part of their trajectory. As you can see here, like in group 1, we had people that received public funded home care, so we do not include private home care. And we also can see here in the group 2 are those people that received public funded home care and then after moved to long-term care. So of all people living with dementia that had home care after their first record of dementia, we found 46% of people went to long-term care. And we also identify a group of people that did not receive or were not identifying the public home care data or in the public home long-term care data. So 26% did not receive public home care, long-term care, but they could be receiving short stay home care. So when we're talking about home care here, we are talking about the long stay home care. So for that group 4, they were not receiving long stay home care, but they could be receiving short stay home care or for example, community support services or private home care. But we also know, for example, that some provinces, they have other models of care, such as in Alberta, where they have assisted living care, and we do not capture this data. And we also have some regions that do not submit home care data to CoE. So we have some information about this group, but it was still interesting to report. So then we looked at the primary care providers. So in this graph here, we can see the percentage of people living with dementia who had their first record of dementia in the community by physician specialty. So in the community, for most people living with dementia, dementia was recorded for the very first time by a family doctor or a general practitioner. So 83%, as you can see in the green bar. 30% of people living with dementia had their first record in a hospital. And we also saw that for this group, the majority of people that had or the greater proportion of people that had a record of dementia in the hospital were more likely to come from a low income neighborhood. And we know that family doctors are crucial for providing us various aspects of dementia care. And for example, in our Commonwealth Fund from 2022, in that survey, we found that only 35% of family doctors in Canada felt they were well prepared to manage dementia care in the community. So more than half of people living with dementia had home care as part of their trajectory. So we saw that was 58%. So in group one, people who lived at home and were also supported by home care represented 31% of people from our cohort. And in group two, people who originally lived at home and then were supported by home care, but eventually moved to a long-term care facility represent 27% of our cohort. And so we looked at factors that were related to people that were receiving home care and then moved to a long-term care facility. So we looked at a broad range of different of factors. For example, we looked at caregiver factors. So for people living with dementia that had a caregiver that were experiencing distress, anger, or depression, or if they reported feeling unable to continue in their role, or caregivers that were not, or people living with dementia that had a caregiver that did not live with them in the same house, for example, they were more likely to go to a long-term care. So people living with dementia that had caregivers experience, those feelings, were more likely to go to long-term care home. Then we look at clinical factors for the person living with dementia. So if they had a high level of cognitive impairment, or they experienced severe hearing impairment or frequent wandering, they were also more likely to go to a long-term care in comparison to those that did not experience the same clinical factors. And then we also look at some equity factors. So for people living with dementia that at the time when they were in home care, receiving home care, they were living in a low neighborhood income area, or if they live in a rural area, or if the person living with dementia were a widow or widower, or their first language was English, then they were more likely to move to a long-term care. So it's interesting about the language piece, and we are going to see some quotes from one of the caregivers, where we also heard, for example, we saw in the Alzheimer's Society of Canada report, we saw that caregivers share some stories highlighting the need for cultural appropriate care and resources for people live with dementia and their caregivers. So we heard from caregivers that sometimes they were looking for a long-term care home where they had, the staff speaking the language of their family member, and they couldn't find these types of homes. And then it was very hard for them to, have an admission in a place where there was not a cultural appropriate services for their family members. So here you can see a quote from one of the caregivers that we interview. So how she was saying that in her culture, for example, even it's not only about the language, but about how if you send your parents to assisted living long-term care, you really fewer are frowned upon, and can also be very hard to find Mandarin speaking care providers, which is another barrier. So it's not only about the services, but sometimes for some cultures, there's a perception that having a family member going to long-term care is not something that they are expected to do. So we also saw that at least 1 in 4 people who had a diagnosis of dementia or their first record of dementia were not receiving home care and were not in a long-term care facility during the 5 years after their first record of dementia was identified. So again, as I mentioned, there was a group of people where we couldn't identify that person in any of our home care databases or long-term care. So that is the group number 4 here. So 37% of people in that group lived in higher income neighborhoods. So they are more likely to live in those higher income neighborhoods. So it's possible that they were paying for private home care, but we don't have the data to show that. And also they were more likely to be younger than the other groups. And so it's also possible because they were younger that they didn't have symptoms, so they could, I guess, live more independently. But also we do not have, for example, data on other services. So it's possible that people in this group they were receiving service from community support service, for example, or as I mentioned, from private home care that is not capturing our databases. But still, it's very interesting to see that there is that number of people that were not in the public home care or public long-term care. And when you look at caregivers of people who live with dementia, we notice that our results are consistent with our previous report, where caregivers of people who live with dementia, they're more likely to experience distress compared with caregivers of people without distress, as you can see here in these bars. And also they are more likely to provide more hours of care per week compared to caregivers of people without dementia. So it's like 20 caregivers of people living with dementia providing average 24 hours of care per week compared to almost 20 hours for the other group. And we also, when we looked at caregivers that are caring for someone living with dementia, those caregivers that are living with the person they were caring for were more likely to experience distress compared to caregivers that were not living together with the patient or the person living with dementia. And then in our analysis now, we moving to hospitalizations before admission to long-term care. So we saw that hospitalizations often precede long-term care facility admissions, especially for those living with dementia without home care support. So you can see here in these bars, if you look especially those bars before that dotted line, so the dotted line is the long-term care admission through time, and you can see that just like 3 months before a long-term care admission happened, for the group that is the green bar here that were receiving public home care, they are more likely to have less hospitalizations compared to the group that's representing the other bar, the group of people live with dementia that did not receive public home care. So there's a big difference here. So more than 4 in 5 people live with dementia without any previous home care support had a hospitalization in 3 months before their admission to long-term care. And the other interesting fact that you can see in this graph is that after long-term care admission, regardless of the group, the number of the proportion of hospitalizations decline dramatically after they got admitted to a long-term care. We also looked at alternate level of care. So alternate level of care refers to patients that occupy an acute care hospital bed but do not require the intensity of services provided in acute care. So commonly patients in alternate level of care are awaiting transfer to another care unit or facility, or they're often waiting for a spot in a long-term care home. So we saw that most people living with dementia that had this designation of alternate level of care, they were awaiting for a long-term care facility placement. And in our data, 30% of hospitalizations for people living with dementia had AOC days, compared to only 7% of hospitalizations for people of the same age group without dementia. And we also saw that hospitalized people living with dementia who were younger had more AOC days. You can see here. So the younger group, the age group 65 to 74 years old, they had 42 days as the length of stay for the AOC day, compared to 25 days for the age group of 95 or older. So here are some quotes from our providers. So Charlotte, a home care nurse, she said that the majority of our clients with dementia get referred to our home care services from a doctor's office or the hospital setting, often a crisis situation like an acute delirium related to an infection or some other worsening condition. And then we heard also from Dr. David, a family physician and also caregiver himself, that when someone is in hospital and showing signs of severe impairment, you can't send them home alone. There needs to be somebody there to look after them. And if there isn't, you cannot just discharge them. So you may end up with some AOC days. We also looked at hospitalizations for people living with dementia that had concurrent mental health and or substance use disorders. And you saw for that group, if they had dementia and also concurrent mental health or substance use disorders, they were more likely to have a designation of an AOC patient. And also when they were in that designation of alternate level of care, they are more likely to have that for more days. Number of AOC days were longer, higher than compared to people living with dementia without that concurrent mental health or substance use disorder. So that happened regardless if the hospitalization happened before home care admission or if the hospitalization happened before long-term care admission. If that was present, the person was more likely to be a AOC patient. We talked to Susan, a caregiver of person living with dementia and also concurrent mental health and substance use disorder, and that's what she said. I feel like we have to navigate 3 separate healthcare systems to get support for my father's dementia, mental health disorders, and substance use disorders. But you can't just take one diagnosis from the other. They're all connected. It's very stressful and hard to navigate. So now we are going towards the end of our key findings. So there are some factors contributing to the interpretation of the findings. So dementia is not always consistently captured and recorded in our databases. CAI collects data only on publicly funded long-term care facilities and home care services and drug claims. So we don't have data, for example, about private home care. Assisted living model of care that's implemented in some province, as I mentioned, in Alberta, is not, this data is not fully captured. And the analysis also includes data from the COVID pandemic period. So the pandemic had broad impacts on healthcare use and therefore might have effect which services people assess during this time, as well as their outcomes, their health outcomes, and this is not measured in this report. So in conclusion, the breadth of CAI data sources really allowed us to follow people live with dementia through different trajectories in Canada's healthcare systems. And people live with dementia, as we saw, follow a variety of healthcare trajectories that are often a result of the supports they have available in the community, especially from their unpaid caregivers. Thank you. I'll be happy to answer any questions.
Thank you so much, Raquel and Liudmila, for this amazing presentation and for sharing your expertise with us. I guess it's now time for questions. So if you have any questions, please just type your questions in the Q&A box below. Wait, see if. Oh, I think there's some. Okay. Oh, no, not yet. There's comments. Well, while we wait for people to add some questions, maybe I'll start with a question. Was there anything surprising that came up with regards to the predictors to the transition into long-term care?
Thank you, Anne, for the question. So I think something that comes up when we present this work about the predictors of long-term care homes for those that were receiving home care is the equity factors. I think especially the English as a first language always like comes up, and when we mention that we talk to caregivers and that sometimes they are looking at services in long-term care that have that are culturally appropriate for their family member. Often when we share this information, it's amazing how that resonates with a lot of people. But I think it's interesting finding, and which it makes sense with a lot of things that we hear from family caregivers.
Thank you. We now have a question from Jeff Dutai. Did you say that you were not able to analyze data as a function of models of home care, even for just the province of Ontario?
I'm not sure if I understood the question. We were able to look at the home care data that we have, which is only publicly funded home care. But we do not have information, for example, for private out-of-the-pocket home care. And also we do not have data on community support services. If people are receiving, for example, any support from Meals on Wheels or Alzheimer's Society, unfortunately, we do not have this other type of data available. I don't know if that helps answering the question in terms of models of home care.
Well, I'll say, Jeff, if you need additional clarification, just add to the question, the Q&A box, and we can go back to it.
Yeah.
Can you talk about the trajectory once they are in long-term care and how to talk to families about it? So not the transition part, but the trajectory, I guess, once they are actually into a long-term care home.
Yeah, we unfortunately we don't have, like, for this project, we didn't look at what happened to the person like after they had admission to long-term care. We did a lot of exploration, things interesting, looking at cognition and how that sometimes change, and how the importance of that, the activities they have, that socialization that happens in long-term care. So I think for us, we learn a lot about the good things that happen in long-term care. And that was something interesting, but in terms of data, we do not have anything that we're able to share for this project, because it was limit the scope that we had to explore. I don't know if Liudmila, if you want to add anything about that, but
No, I think you covered it, Raquel.
Well, we look forward to follow-up work. And you know that I do some work looking at the trajectories once individuals actually move into long-term care. So I would definitely love to see some more work in that area for sure. So Anne-Marie Steele has a comment. She says, just a comment. The data with regards to the dementia patient's hospital to long-term care stay seems this could explain the wait times for non-urgent long-term care applications. So I guess like the data that you've presented with regards to the patient's hospital to long-term care, patient's hospital to long-term care stay, that might explain the wait times for those non-urgent long-term care applications.
Yeah, definitely. It's something that I would say, yeah, it would be linked to that. That the fact, yeah, there's a lot of people waiting, and and we also mentioned that how the younger people that live with dementia, they are more likely to have longer AOC days, or stay at, have this designation, and when they have this designation, they're more likely to stay in the hospital, because I think it's at least intuitive that for older adults, they would be the ones in the priority list, because they probably would have more comorbidities. So you can see how that would have an impact on the AOC days when they are waiting for a spot in long-term care. So there is maybe something that we heard about, how you can have like services for this younger population too, how that's sometimes more maybe complex to find a spot. So yes, definitely I agree with that comment, that a lot of our results are a reflection of that situation where people are waiting because there's not enough beds for everyone in long-term care.
We have more comments. Will your results be used in any further or future modeling of care?
Well, I don't think we will be using that this time. I mean, maybe Liudmila can also talk about that. But for this was like a project that was funded under this dementia umbrella from the Public Health Canada, and we're lucky to and happy to be part of that group of projects that were receiving that funding for exploring different aspects of for people living with dementia, and we're looking at the trajectories. So for now, we don't have any plans, but we definitely are going to keep everything we learned from this project, as you mentioned, and for maybe future projects, we can continue that exploration. But there's nothing like for now.
Yeah, but we hope the data might be helpful for researchers who want to use the described trajectories in their work to do some prospective modeling, probably, and future modeling. Hopefully it will be helpful this way.
Yeah, I definitely find your results are quite exciting, and I see the use behind them. So, how are your findings being mobilized, and used across healthcare organizations?
Well, I guess that's the portion that is hard for us to assess. So
Yeah.
if you hear about anything, please let us know. We're always welcome feedback. From our end, we try to do as much, knowledge transfer activities as possible. So this presentation is part of it, but we also had conference presentations. Try to share the results there. There will be a podcast episode which use the findings, but will not talk about them in a similar way. So yeah, I guess we hope that they're being used. And again, if you know of some examples, please pass them along to us.
Yeah, it's definitely like this work helps to bring awareness to different challenges that are faced by the people live with dementia, but also by family caregivers. So I think that's a big part of this work, is to shed light to those challenges, and even the piece that for people living with dementia and concurrent mental health and substance disorders was something found interesting in our project, and even showing that type of result and findings. I think that it's when yeah, bringing awareness, but unfortunately we don't know how people are using that information. Yeah, let us know.
I love how you also complemented the CoE data with the, the patient engagement interviews and that piece. It's kind of shed some light on some of the results that you found. So congrats on that for sure. We have another comment that's somewhat related to this, but I will still ask it because it's a bit different. So could you share some policy level implications from your study to transform care for older Canadians living with dementia or at risk of dementia?
Well, I definitely can see like so many different things that can be done to improve their trajectories. And we saw that home care is a big piece, right? Like we saw that more than 50% of people with dementia, they go through home care, and how when they are living at home, they are very likely to have a family caregiver. So then I hope that with our findings, maybe there's more support for that home care, but for family caregivers that are caring for someone at home. I also mentioned like the equity piece for long-term care that have cultural appropriate services. I think that information, hopefully there's some policy that can help to address that type of service that takes care in consideration the differences in culture. Yeah, I think there are so many things that in terms of policy that could be done to improve the well-being of people with dementia and their caregivers.
Thanks. Will, another question. There's a lot of questions, so good thing there's a lot of time for questions today. Will the patients with no family doctor experience a more difficult trajectory of care?
We are not able to answer that with the data. I think that's definitely, I think from our Commonwealth Fund survey and from this project, but we can say that they are often the first contact, and if there isn't that involvement as primary care, I can see how that can be difficult for navigating the system and get how a lot of the trajectory starts with that first point of contact with primary care, that guidance in so many ways. So I hope we can maybe in the future have some project where we can explore that and understand that question better. But yeah, we definitely show how their involvement, it's something important in terms of diagnosis and the first contact.
So Jeff Jutai did provide some clarification to his previous comment. So the comment is there are many forms of public home care services.
Okay.
Were there any particular forms or combinations that were predictive of moving into long-term care?
That's a very good question, and we thought about, there's some data that we have in terms of, if it's, for example, physio, rehab, or some social worker, nurses, and types of, I'm thinking of different types of care provided by home care. But the data that we had was not, I guess, like solid enough or good enough for us to explore. And also, there was not enough information for us to explore and then make conclusions based on that. But yeah, I think that's a great question. It would be very interesting to know that. And we hope, like, maybe in the future, if you get more data and better data, we can do this kind of explorations. Thank you for the question.
So it seems like there's a lot more work needed in this area for sure. All right, so then there's another question. I'd like to ask if, okay, so does the length of time staying at the hospital when a family member is choosing a certain long-term care home for their loved one? I would like to ask because I work at a hospital and I can see that almost 1 to 3 months, that there's an almost 1 to 3 month waiting time before just discharge to a long-term care home. So I think the question might be, maybe if it's also the fact that the family members take time in choosing a long-term care home. Is that the question? Maybe if someone can clarify. I don't know if I'm understanding the question.
I think it's the question, Annie. I think the question is whether family members choosing a certain LTC home will impact the wait times. We couldn't look at that because we wouldn't know what's happening with families and how long they take to make decisions and why people are, essentially we see that people living with dementia have longer ALC days and stays. So we think it's, there are many contributing factors to that, and this factor may be one of them. We also know that different jurisdictions have different legislations in place in terms of how people are being placed in long-term care homes. So just kind of being mindful that it's probably variability across the country as well.
Thank you. And if the interpretation of the question was wrong, just let us know in comments below. Do you have any suggestions on how to help the family who needs to access home care for their parents?
I think also that depends on where you live, and right, like I would not be able to give advice on that, unfortunately. I would say no need to go through your government, I guess, website and try to find information. And I guess we talked about the primary care, the doctor, family doc. If there's a family doctor, usually they can help you to navigate the system and can help you with providing information how to get started in finding services from other sectors. That would be my suggestion, but that's like me, Raquel, sits and say I not based on our project. I think that we hope that the primary care providers, they are often the person, the group of people that can help to initiate those next steps in navigating, like for getting access to other services.
Yeah, and maybe I'll add also, not from CoE perspective, just from my personal perspective. When I had to, so my mother needed to have nursing care. So sometimes the doctor will send the application, but it may get sort of delayed in the system. So maybe call in the office and check in what the application is. Maybe that can help. We also measure wait times for community wait times for home care services on CoE and publish it in the Your Health System tool. So again, you can see the results by jurisdiction. So it will show the average of number of days people are waiting to receive home care. Maybe not as helpful in individual situations because all situations are different, and in terms of complexity of patients and the arrangements and everything. But that's the information we have available in the sort of other section of CoE website, not exactly in this report.
We have another question that is again around the culturally appropriate language piece that you discussed and how it's difficult to find. So someone had a comment around, my father, an English speaker, has mostly PSWs with thick accents. lovely people, but extremely difficult to understand, especially given he has an hearing impairment. And so that sort of adds to that that piece of language. And I do like think that the language piece and the culturally appropriate, long-term care homes is important. And it actually was the initial. So, we have an intergenerational volunteer program that links students with people living with dementia in long-term care homes. And the initial funding for that program a while ago, when I was a postdoctoral fellow, was actually from Health Canada in order to have more volunteers working or being next to people living with dementia in their language of choice. And so we, being at the University of Ottawa, we made sure to have English and French speaking students and other languages as well being matched with people living with dementia to volunteer and spend time to meaningfully engage with them. So yeah, the language piece is definitely something that's important to consider. There's another question around I guess still like around that equity piece. Do you know more about like the age and gender in the various groupings?
Yes, we do have information about that in the report. If you go to the PDF, we do have the age groups, and I would say that in terms of gender, I'm trying like to think of I don't have on top of my head the results, but in terms of comparing the groups, they were very similar. The proportions of female and male very similar for all the different groups. The only thing in terms of age that was a bit different was that for that group of people live with dementia that we were not able to identify in the home care data or long-term care data, they were more likely to be a bit younger. So then we're thinking that maybe that could be one of the reasons why they were not yet receiving public funding home care and long-term care, but it's all like some assumptions. Well, we do not know for sure, but it was the only thing that we saw different in terms of age, because in general, the age groups were very similar, regardless of the different groups where they were.
Interesting. Thank you. Are there plans to connect with the Canadian Coalition for Seniors Mental Health to share findings related to the findings around mental health and substance use disorders?
We don't have plans, but I know if people want to connect with us, well, we're always happy to share our findings. As you know, everywhere like people invite us, we are happy to keep going with our knowledge exchange. That's one of the main goals of this work as well, is to share information and exchange information with others too. So please connect with us, and we could definitely present it to other groups.
Thank you. Now, this is more of a comment, but I thought I'd still share with you. Thank you for this information. As an RN and previous caregiver to my mother living with dementia, this can be very difficult and draining disease for family members. Long distance caregiving is very frustrating, especially when the family member lives in an underserviced area with fewer resources.
Yeah, thank you for sharing that. We talked to the caregivers from this that participate in this report, but also other caregivers, and we learned about those experiences. Yeah, and can understand how challenging it must be for you to be living like far. It's hard, especially if you cannot count on services that are provided close by. Yeah, it's a big challenge.
Yeah, and we could not stress the role of family caregivers or informal caregivers enough in this work. We know, as Raquel showed in the findings, that caregivers of people living with dementia experience more distress, provide more hours of care, and certainly, as Raquel mentioned, thank you for sharing your experience as well.
Yeah, and thank you for incorporating the caregiver data in your predictions for the move into long-term care and your analyses, because that's very, very important. What can we do to get involved to improve the services and funding for people living with dementia?
I wish our colleagues from Public Health Agency of Canada were there. So there was a Dementia National Strategy, 5-year strategy, and there is some follow-up activities that are happening. So I kind of encourage you to maybe go to the Public Health Agency of Care website. So there might be some, opportunities or connection to the resources available there, as well as websites such as Alzheimer's Society of Canada, other organizations that work in this area probably will have more related to this question. And Annie, if you can add something, would be welcome to.
Yeah, I think with the suggestions that you've provided are great. I think we just need to speak up about the importance of funding and resources for people living with dementia and their family members, care partners. And the more we do that, the more we'll be heard, I'm hoping. There was a comment about a question around if you'll be able to share your PowerPoint presentations with the group. And just to reiterate, our webinar series is always recorded and will be available really shortly after this on the Center of Excellence website. So you can certainly access the entire presentation afterwards. All right, so another comment. Hopefully, the powers to be will use your study when making decisions. Perhaps sending results to the Minister of Long-Term Care. I think the fact that you guys are presenting this work, it's not the first time I hear you present it. So the fact that you guys are presenting this work repeatedly is definitely more likely to be heard.
I hope so too. Yes, thank you.
Yeah. Yeah, we are definitely have been presenting this work for since the release. We had the release in April, so we hope people can share too. The report is publicly available. We have the PDF. Maybe you can also at some point share the link, and yes, please share this work. I think that's an important comment. It's a way we can help to make some impact, good impact.
All right, so how does I'm going fast because there's quite a few comments and questions. I don't know if we're going to have time to go through all of them. How does your research deal with persons who have moved into a retirement residences who are then diagnosed with dementia?
We had not people that retirement, like we didn't identify people going to retirement home, but in our subgroup, I think we have the group that we call other. We had identified some people that actually were living in long-term care, and they were identified as their first record of dementia while they were living in long-term care. So that group was very small, and we didn't have enough, I think, information to explore and understand, but we definitely are aware, and we identify some people that were living in long-term care when they had their first record. But again, it was a very small group. I'll try to find here the percentage because I know I had the note in our notes, and I think it was 5% of all our cohort. And we also found that other group 2, we had people that had their first record of dementia while they were receiving a public home care. So that also part of the older group. So that happens because, you know, it's an older population very often that's receiving public home care. So it's not uncommon for that to happen as well. So we have identified those groups as well.
Thank you. Not a question, but a comment. I'm from the Ontario Caregiver Organization and find this information helpful in building the case around the growing concerns around burnout. Oops, my question moved. Wait a second. About burnout and caregivers as the population does age and the supports that will be required to address the aging population in the coming years.
Thank you for the comment. I think one thing that I heard in one of our presentation was about how sometimes people may not be aware of a number of people with dementia that are living at home and they are supported by a family member. So home care and the family caregiver. And of course, even when they move to long-term care, the family caregiver is still providing support. So we are also happy to share those findings. We know that the support from family caregivers, as we saw in our findings with the predictions, even with the little data that we have on caregivers, we don't have a lot, but it still was significant to show that in terms of the predictors of long-term care admissions.
Are patients without a family doctor more likely to be diagnosed at the hospital?
Unfortunately, we didn't have data to explore that or understand that particular group. What we know is that people that had their first record of dementia in the hospital, they were more likely to live in a low-income neighborhood. So there is definitely a equity piece there. So I don't know if they did not have a family doctor, but I think it would be interesting to explore that in our next project.
Absolutely. You have really lots and lots of leads for future for future work. Or if there's researchers on the call that also, you know, work with some of the CoE data, maybe they can collaborate with you guys to move this important work forward. There are 2 minutes left. I don't think we'll be able to go through all the remaining. There's lots of other comments. I think maybe what we can do is keep track of these comments and maybe we can share them or these questions with you, and possibly if you are available to provide some answers to those questions, we can also make them available to the people that attended this webinar series. But I wanted to say again a big thank you, Raquel and Liudmila, for this amazing presentation, and thank you to everyone who attended this webinar series today. I hope you all have a lovely rest of your day, and we look forward to seeing you at the next webinar series in the new year.
You're very welcome. It was a pleasure to be here. Thank you for the invitation, and thank you for all the comments, and thank you for all the questions. And hope we can answer them in the future.
Thank you so much.
Thank you, everyone.
Thank you. Bye.